The patients will return. They will return post-procedure, usually depending on the protocol for your practice, but 72 hours, 5 days, 3 to 5 days. But the patients, it's important for them to return, and we do a limited venous exam. This is where we would do a limited venous exam to assess for the common femoral vein and the confluence, a waveform, and we're really paying close attention to this area right here, the saphenous into the common femoral vein. We want to make sure there's no extension of treated vein into the deep system. We also kind of follow this treated vein to the insertion site, to the catheter insertion site, whether it's above knee or below knee. We just kind of follow it with our transducer, taking a couple of different pictures documenting that it is occluded and that it was a successful treatment. But this area here is very important. We want to make sure that the common femoral vein is open. Some complications with the treatment include some bruising, maybe some mild discomfort for the patient, and then DVT, possibly. Post-ablation thrombus. Another term is endovenous heat-induced thrombus, but it's the treated segment of the vein that extends into the common femoral vein. The risk is the same. It can cause a pulmonary embolism. So this is what we're checking for. We want to make sure that this did not happen, that this did not extend into the common femoral vein, because if it does, then it changes how the physician will manage the patient. Over time, we're still routinely following these patients. They're coming in every couple of months, 6 months, year, whatever the protocol practice decides to be. But after several weeks, the vein wall undergoes a fibrosis and can become difficult to visualize. This is what the vein will look like post-procedure in those first few days that we scan the patient to make sure that the treatment was successful. This is what it'll look like, and then several weeks later, it starts to shrink, it blends in with the surrounding tissue, and then months later it becomes very difficult to visualize. And recurrence of this problem is common for our patients even after endovenous ablation therapy. It's common, recurrence is common secondary to recanalization of possibly a treated segment or recruitment of minor communicating channels that were draining into that area. So these patients are followed. They're followed, and we keep tabs. I scanned a patient not too long ago. She had had 7 different procedures to treat her venous problem. Her legs looked really good. Her legs looked great, actually. She really managed her disease very well. And she felt that it was just in one leg. She felt that her symptoms were returning. She's having a little heaviness, and can't recall if they were itchy, no ulcers or anything like that, but she was starting to have some cramping and heaviness and a little bit of swelling. So she came in and had evaluated, and sure enough, there was a prominent vein, accessory or tributary, and it had reflux in it. It was dilated. So she was really managing her disease very well. She had said that for her, it had started in her 20s, and I think she was in her 60s, and very healthy woman. And she stayed on top of it her entire life. I think she wanted to have very nice legs. So in conclusion, normal venous function requires a series of valves to work in coordination with our muscles, our calf muscle pump to move the blood in one direction. Venous insufficiency is a common problem with potential significant impact on our patients and the healthcare system. Venous duplex is a very valuable diagnostic tool in the evaluation of venous insufficiency. Provided we're following proper testing protocols, we are using proper technique, and adhering to the diagnostic criteria, as well as what's required with insurance payers, so that our patients can be well taken care of. Minimally invasive treatment options such as ablation are successful. The patients definitely report that their legs feel better within days. They feel better within days. That's great. That's the purpose, that they feel better. And it's very important to follow our patients post-procedure to identify that we were successful with the treatment, and then identify the possibility of a thrombus, post-ablation thrombus extending into the common femoral vein, placing the patient at risk for a pulmonary embolism.
Lori, thank you. This was amazing.
I can't see a clock, so I don't know what time it is.
It's perfect. Your timing's perfect. We have 15 minutes for
okay.
answer questions. So that's great. And so we'll take a few last questions for the last 15 minutes of this session. So the first question we have is heat used to encourage the vessel to dilate?
Is heat used like a heating pad, or
I
like
think it was in reference to the ablation.
No, the heat is actually causing it to constrict, to scar down. The heat, we can use heat in arterial testing for the artery to dilate, so it's not spasming. We can, for the vein, if we need it to dilate, we can increase the intraluminal venous pressure using that reverse Trendelenburg position. Tourniquets can be useful as well. Oops.
Why do we test the deep system for reflux when there is no treatment for it?
To understand the magnitude of the disease, of what's happening for our patient. And they're doing all kinds of different treatments now. In preparation for this presentation, I learned about they're replacing valves. They're growing valves and actually trying to replace valves in the deep venous system. Sometimes they'll do bypass grafts as well. I'm not sure exactly how it works, and I haven't seen one, but they are doing more and more because of the risk to the patients, the outcome, the poor prognosis with those venous ulcers, and the cost. It's a significant cost for the patient's life, their quality of life, and then for healthcare dollars. So they're doing all kinds of work for this type of disease because it is so common.
Great. When we get the patient on the table just before the laser ablation, should we have the patient in reverse Trendelenburg?
Yes.
Great. And while the laser is in use, the catheter being pulled out, should the patient be in Trendelenburg?
I think that would depend on the provider's preference. I'm trying to think back to the last one I did. I can't recall if he did put the patient in Trendelenburg or not. It would just be, and what's really great too, when you start doing these procedures in your practice and you purchase the equipment, whether there's even glue now. They even use glue that was recently approved, and more insurance companies are starting to approve it for their patients. But whether it's ablation or glue, the vendors that are selling the products, they will share with you the best practices for the best outcomes for the patients. They'll even do a couple of procedures with you and your provider that offer you ultrasound support as well as physician support to make sure you have the tools to do it successfully, and explain whether or not the patient should be in Trendelenburg at that final stage or not. They'll be with you during the entire procedure for the first couple of however many times you want them.
Thank you. Is treatment the same for patients that already have venous ulcers? Is it just about managing their pain, or is there any way that their ulcers can be healed?
They're trying to heal the ulcers. They want to heal the ulcers. So they can treat the perforators if there's incompetent perforators in that area. They can treat the perforators with possible ligation. I'm not sure if they inject in those areas. I don't think so. I think it's just ligation of the perforators, and then also treat the superficial system as well. But they definitely, they want to try to heal the perforators or to heal the ulcers. That's the goal. It's because it's a source of infection.
Can you explain a tributary vein? What's the difference between that or a perforator and anterior posterior?
The tributary, well, let me go back. Let me go back here. Let's talk for the perforator here. So that might be too much of a close-up. The perforator is a communicating vein. It's a communicating vein between the superficial, let me go all the way back to the beginning to our anatomy. So the perforators, they are a communicating vein between the superficial and the deep system. So they allow blood to flow from superficial system into the deep system and then back up towards the heart. That's what the perforators are doing. So they perforate the muscular fascia into the deep system from the superficial system. And then your tributaries are these branches that drain into the saphenous system. And there's a lot of them. There's a lot of them. There's a lot of veins that drain, especially in this groin area. There's some veins that are draining into the saphenous and then into the deep system. And then the tributaries that are draining into the saphenous. And then there's also accessory veins, and they're all superficial. They're all superficial veins that their function is to keep blood close to the surface of the skin to help regulate our body temperature. But with that increased venous pressure, intraluminal venous pressure for years, as we stand in maybe some of our jobs, we're standing for 12 to 15 hours, that pressure starts to degrade the vein and we end up with incompetence. All of the superficial veins. The saphenous vein and its tributaries and the short saphenous vein is where most of the reflux occurs.
On the topic of perforators, if a perforator is very enlarged and you're having a difficult time getting reflux, what do you suggest?
They will, if you can't get reflux, they will consider it incompetent based on size.
Great. And then with regards to size, when measuring the diameter of the vein, is there a specific reason why measurement is performed AP instead of transverse?
My understanding, and if there's anyone on that can add to it, but with ultrasound, we have better resolution AP, so we can see better AP.
If a patient has an ablation procedure, are there instances in which a second or multiple procedures are needed, and how soon after the initial procedure can that be determined?
I don't know if there's a time frame. I think that from what I've heard with the physicians that I've worked with, when the patients come in for their post-procedure scan, typically the patients are feeling better right away, but they usually explain that more of the veins will start to close off because they don't have anywhere to drain into. So if your saphenous vein is treated and it's got the post-ablation thrombus, so they're the tributaries and the accessory veins that drain into the saphenous, they can no longer drain in there anymore. So they start to constrict and become smaller, possibly over time, so that they explain that give it, in a little bit more time, these veins should close off. I don't know. I haven't been, I'm trying to think back. I haven't been with a patient that immediately had another procedure. I think that you have to consider also the insurance and whether or not they would pay for it. So I think that it's definitely a period of time.
Is there a high demand for techs who specialize in this type of work?
Well, I think there's a lot of, definitely a lot of vein centers. This is, you know, we saw the statistics. It's a very common problem for our patients. And you know, I love vascular ultrasound, so I'm going to say yes.
And what is the length of a diagnostic venous insufficiency exam?
They can typically, depending on your protocol and how much information you are required to actually document, or and what I'm trying to say is some places want a lot of pictures. They want every single step documented that you're taking, while other practices need to just see more of the highlights of your exam. So it really depends on the number of images you're required to take for your reading physician. Typically, they can take between 30 minutes and an hour, depending on what's going on with the patient and how much you have to document.
Thank you. Michael LaJoy from WCUI has responded to your answer with regards to the AP dimension.
Oh, thanks, Mike.
That axial resolution, or AP, in the case of measuring a vein is much better in most systems. Is his answer.
So it is the physics, right?
Physics.
Resolution. It's that dreaded physics word. Ah. Go ahead, Mike. You can have it.
Okay, are there a couple more questions have come in? Are cine loop clips used at all for this study?
Yeah, you could definitely use cine loop. That's a great idea. You could definitely use cine loop. The places that I've worked, caution with using cine loop just because of the storage within packs, and even on your hard drive if you're using a hard drive. But certainly cine loop can definitely capture the reflux.
Great. During the venous insufficiency study, have you ever seen a clot in the greater saphenous vein, or SSV?
Yes, definitely. And even calcifications within the short saphenous vein, a lot of them actually in the short saphenous vein, right about just about the distal popliteal fossa area. I think maybe, you know, how we sit in our chairs and cross our legs. I have seen a lot of chronic changes within the short saphenous vein, and we just document it. And even in the greater saphenous, and we just document it, and then start paying closer attention to the tributaries and accessory veins, because they could be causing the problems for the patient.